coming from a completely different perspective, I would request Dr. Pandey to talk about his experience, his international experience, on what are the challenges that organization, the supply side faces while dealing with patients who come with government provided coverages, and how did other countries, for example, Cuba, Costa Rica, and you don't have to go that far, Sri Lanka and Bangladesh has achieved tremendously in health sector, health outcomes in general in the past decade or so. So if you could share your experience from other countries, how they have tackled the problem of providing healthcare, quality healthcare services in other countries, especially in Southern Asian countries.
Since this is a public finance conference, we've had a lot of talk around finances and financing over the last 2 days. But I think the issue around healthcare delivery in Bihar, as elsewhere, is a two-part problem. And it's first a part around financing. The second, and I would consider the more important and the more challenging part, is around delivery. And we've not talked at all about delivering healthcare, the nitty-gritties, the operational details of delivering quality healthcare to people. That's part because I think the conversation's primarily being driven by people from the Ministry of Finance, economists, and people like that. I think we, in the provider side of things, health services researchers, physicians have let the ball drop. We have not offered solutions. So I think I will try and tilt the table a little and then focus the conversation on that part of the equation. But even before going into the topic, I think it's important to understand what the real problem at hand is. I think someone said the most corrupting of lies we tell ourselves is that of a problem poorly stated. I will try to see if I can state this problem right. And here in Bihar, as well elsewhere, I think this is a four-part problem. First is around that healthcare financing in Bihar, health spending is half of that as anywhere else in India. And even at a national level, even compared to low middle income countries elsewhere, India's healthcare spending is already abysmally low at around $260 per capita per person. Financial jeopardy for around 10 million people within the state of Bihar. Health facilities that don't function, or even when they do, they don't provide the kind of care that improves health outcomes. And I mean, even when there's health intervention that people have access to, that does not really improve health outcomes. And what's going to happen with Ayushman Bharat in each of these four domains? And I think we have an answer to all these questions with the foregoing presentations, especially the four presentations that we just had. Funding, I mean, abysmally low, probably Ayushman Bharat will improve the funding situation. It's less than 1% of the state GDP. Maybe this will go up. Let's be hopeful there. Financial protection, there's been conflicting evidence presented even within this conference. It could be a hit or miss. I mean, there could be some financial protection. There could be some income effects, as Anup just pointed out, but some other studies have shown that there might not be any financial protection. Health facilities that function, healthcare utilization that improves, Anup just said maybe not. Health effects, will there be promising health effects? Likely not. Why is it so? We're willing to spend billions of dollars here. We're committing already 10,000 crore rupees, and we sit here and decide and tell ourselves that there's probably not going to be health effects, but let's go ahead and do this anyway. Why are we doing this? But I think the problem at hand is we're not stating the problem right, as I just said before. And the problem is, it's not just a financing problem, it's a delivering problem. It's providing the right kind of health care, a care that makes a difference. And do we have examples of that? And the reason we get into a situation like that is because we are confused about what the problem is. And the confusion comes from this. And the confusion is that we're conflating between healthcare and health. We tend to think that providing healthcare in itself is going to deliver health effects, which has not been shown anywhere. I mean, you can provide, in fact, a little bit of insurance covers, and then you can do all these hysterectomies and then kill women and have terrible outcomes. And in fact, instead of helping people, you're actually hurting people, all the while wasting taxpayer money. So, and the second confusion that we have is, where does healthcare production really happen? I mean, there's been a great deal of theoretical work around this. Michael Grossman, back in the 1970s, put out a wonderful model, his health capital model, where he said that healthcare production happens not just in health facilities, but a lot of the healthcare production happens within families, within individuals taking care of themselves, within family members taking care of themselves, with communities coming together to take care of themselves, with communities acting in tandem in order to act upon the social determinants of disease, nutrition, sanitation. And primary healthcare centers that really provide the nitty-gritty of care, 80 to 90% of the actual pathology that afflicts our societies. We need to address those. None of the insurance schemes that are being discussed after 1993 all around the world, not just here in India, but anywhere else in the world, discuss any of these things. The only thing that we talk about is providing a certain amount of coverage, covering services at tertiary facilities, and then we go on and find 5 years later there was probably not even utilization effects, certainly not health effects. Why are we surprised about this? There's no reason to be surprised. The reason we should be surprised is that we're not talking about what really we need to do in order to build health systems that really provide healthcare for people. And I just don't want to sit here, point at problems. I want to be part of the solution. I mean, I think, as I said before, we are the people who let the ball drop. And the way to answer that question is to look at health systems, country health systems, and community health systems that have really delivered the goods for their people. And I want to point at 4 examples from around the world. I want to start here in India itself. I find it a little surprising that nobody talks at this example. There is a little wonderful experiment. It's not even an experiment. It's a real thing going on in Jamkhed in Maharashtra. I'm not sure how many of you are aware. 2 wonderful doctors started this back in 1970s and provided this comprehensive healthcare set of healthcare packages attacking the social determinants of diseases, providing income support, and providing the basic comprehensive health coverage that people need in order to improve their health. And they've gone on to improve their health outcomes as well as anyone else out there. Their infant mortality rate today is 17. Their health expenditures are very minimal. We do not want to, we do not care to scale that sort of model because that's a very hard, difficult thing to do. Elsewhere in Sri Lanka, they've done a very similar thing, very strong community-centered, public-owned primary healthcare facilities, and they've been able to achieve health outcomes that are at the top of middle-income countries, all the while spending only $350 per capita. That is as good a health outcome as anywhere else out there in the world. Everybody's talked about Thailand, and everybody's pointed out about the 30-year work between 1970 and 2000 that went on in order to build primary healthcare systems in that country. You might be surprised to know, we talk about healthcare expenditures being perennially low in India, but you might be surprised to know that India spends around 3.94% of its GDP, although it's only around 1% of the GDP that the government spends. 4% of GDP is spent in healthcare in India. Thailand does the same thing. They spend 4% of their GDP. When they started out with UHC back in 2001, they only had $1,900 per capita per person. But today they spend around $600 per capita on a purchasing power parity basis. Their actual spend is around $370, $400. And they have health outcomes as good as anybody else in the middle income world. So what did they do right? They did a few things right. I mean, as we pointed out, they built primary healthcare systems. Second, when they started out with UHC, they shunted off money from their central hospitals into these primary care systems. Nobody talks about that because it's not pro-market probably. It does not expand on business, but that's what they did. They also limited all their health expenditures to government expenditures. So 86% of health expenditure in Thailand happens within the government system. Only 14%, that's a lot of medical tourism that happens in the private sector. So these are the kind of innovations that you have to engage in. But a very interesting example, what I would consider the stellar example of reformatting your healthcare system in order to deliver the goods for people is from Costa Rica. I mean, and that was not easy work. That took 50 years of work. It started in 1961. Even before UHC became fashionable in 2005, even before Health for All became fashionable in 1978, Costa Rica started out in universal health coverage for everybody back in 1971, with an aim to providing healthcare for everybody in 1961, with an aim to providing primary healthcare for everybody in 1971. They did well for 10 years. It didn't go as well as they thought, but they did focus a lot on building those, the difficult part of building community-centered healthcare systems. So they built this system called Rural Health Program, where around a population of around 5,000 people would be in charge of a doctor, a nurse, a pharmacist, a medical clerk, and an information person, and they would not only provide a comprehensive set of healthcare interventions, but they also would go out and reach to the community with a community health worker and provide all the things that they needed to do in order to link up people and their livelihoods with the healthcare system. So that has paid rich dividends over, the 50 years. The other policy innovation that they did was they actually decoupled their primary healthcare system from the Ministry of Health. And they put it into their Social Security scheme. What that ended up doing was the funding cycle was predictable. I mean, the money that came in from the Social Security scheme was always there, even in the low days, in the dark days of 1980s when neoliberalism and contraction of the state was expanding all across Latin America. That did not really affect health systems in Costa Rica as much as they did in, say, for example, Mexico or some other countries. So that has resulted in a situation where, although Costa Rica spends around 10 to 12% of what per capita health expenditures are in the United States, their infant mortality rate is comparable. Their life expectancy is, in fact, slightly higher than the United States. I mean, sad as it is. So focus just on primary healthcare system. That's the kind of achievement that you can have if you focus on providing the right kind of care. But that's a very difficult conversation to have, and that's an even difficult thing to do. So we don't talk about that enough, and I think we need to talk about that more if we are going to have even a passing shot at improving health outcomes, at improving healthcare delivery systems in Bihar by means of Ayushman Bharat. If we don't do that, we've had 15 years of state-level insurance experience in India, and none of that has really delivered the goods except in some exceptional situations. And I think that's all that's going to happen. At best, what we're going to see is an expansion of the private healthcare delivery systems without a commensurate increase in delivering the healthcare goods for people.